It's my distinct pleasure to introduce our speaker, Dr. Jen Stevens-Lapsley. I've known Jen for a long time. We were kind of in the same cohort of PhD students at the same time at different institutions, see each other at meetings every year. Been following her career ever since then. Just to tell you a little bit about her, she did her PT degree and PhD degree at University of Delaware, did a postdoc at the University of Florida, worked with some of the top people really in the field, Lynn Snyder-Mackler, Stuart Bender-McLeod, Krista Van Den Born, worked with a lot of the top people. She got to the University of Colorado, I think, in 2006, and really quickly rose to the ranks. She's full-rank professor in 9 years, so she's doing very well. Has received a number of awards, grants. I actually had to look up one of your grants, R53?
R56.
R56. I didn't know what an R56 was. It's a one-year grant.
It's a consolation prize.
So, I had to look that up. So anyway, we're very pleased to have you. Thank you for coming, and I think you'll all enjoy the talk. So.
Thank you. Thank you very much, Scott. Let me start by making sure, is the mic working? Okay, wonderful. So thank you for that very kind introduction, and it is truly a pleasure to be here. I've heard so many wonderful things about the University of Alabama, and this has been a really nice opportunity to meet many of the people that are tied to many of my interests and lines of research, and certainly see firsthand the expertise that's here. So thank you very much for the invitation to be here, and I'm going to be talking today a little bit about a combination of different, both mechanistic-based kind of applications in terms of questions related to quadriceps muscle function, as well as the clinical kind of side of things of how do we take some of the work that we're doing in a research setting and translate it into real-world clinical practice, especially with an evolving current state of healthcare. So just so I have a sense of the audience, how many of you have clinical backgrounds? Clinical degrees of some sort. How many of you are more exercise physiology, exercise science? Great. So we have a nice representation of both ends of the spectrum, so I'm hoping that this will speak to both audiences. And I know many of you have kind of a combined interest, which is where I kind of sit in terms of between those two worlds. So I'm going to start out with my favorite patient. The resemblance to Santa Claus is indeed very much the case. This was one of our first patients to enroll in one of our neuromuscular electrical stimulation studies when I was a doctoral student. He had a bilateral knee replacement, or simultaneous bilateral knee replacements. And I remember him sitting in the waiting room one day with a little 6-year-old girl who looked at Santa Claus. He dressed, usually with his red suspenders as well, dressed the part on a daily basis, and this poor 6-year-old was panicked. It was June, and she was very concerned that Santa Claus was not going to make it back in time for Christmas to deliver presents. But he assured her that he was going to make it back, and his rehab was in good hands, and he would send her a postcard when his rehab was complete. So on the very last day of treatment, he came in his full Santa Claus gear with shorts instead of pants, so that he could demonstrate the use of neuromuscular electrical stimulation as a fully suited Santa Claus. I'm going to be talking largely about knee arthroplasty, but we use knee arthroplasty as a model for a variety of different muscle disuse, but other different conditions that parallel some of the profound dysfunction that we see in patients after knee arthroplasty. So there are more than 750,000 of these performed each year right now in the United States, but more shockingly, that number is going to increase to, or is expected to increase to 3.48 million by the year 2030. That's a pretty substantial increase in the volume of these procedures in a relatively short period of time. So as our baby boomers age, we're going to see a larger proportion of individuals needing this particular surgery as a result predominantly of osteoarthritis. And so this just basically depicts the increasing number of individuals that are expected to have osteoarthritis over the next few years, the next decade or so. So I'm going to also frame what I'm going to describe in the context of some of the new CMS requirements for bundled care. So those of you who may not be familiar, as of a little over a week ago, CMS finally, there was legislation that was finally passed stating that there are 68 cities around the country that have been randomly assigned, I'm not sure how random, to be part of this initial operation to see whether or not we can bundle the cost of a knee replacement surgery and pay the hospitals that initiate the episode of care for the services, all the services related to that particular surgery. The idea is, of course, to try and increase the incentives for continuum of care, so quality of care across multiple different settings, reduce costs, and allow people to be a little smarter about how they approach the postoperative phase of this particular surgery. Incentivize people to basically be more efficient. And so we're going to see how this works. This is going into effect in April, and it is probably one of the fastest changes that I've seen in our healthcare system of conceptualization to implementation, and there's a lot of scrambling going on right now as to what this is going to look like and how people are going to adapt to these new requirements. And so I will thread this through at the end of the presentation to kind of bring back some of the elements of what I'm going to describe to how are we going to use what I'm going to describe in terms of mechanisms of quadriceps dysfunction and apply some of the knowledge that we have to accommodate for this new changes in healthcare. So what I'll start out by saying is that a knee replacement surgery is very successful at reducing pain. That is the primary indication for having the surgery, and there is no doubt that a large majority of patients are very satisfied with that particular outcome. There's a substantial reduction in pain. Similarly, people generally have a pretty good range of motion following surgery. You need about 110 degrees of knee flexion in order to be functional. And so most people get between 0 and 110 degrees or more of knee flexion. Sorry, 0 of knee extension, 110 or more of knee flexion. But what we've shown is that knee range of motion really only limits patients acutely. In other words, in the first couple of weeks after surgery, maybe the first month, patients may experience difficulty with activities of daily living that are specifically related to the decrease in their range of motion. Getting up and out of a chair is not, it can be a little bit limited. Going up and down stairs can be limited early after surgery. But by and large, later down the road, there is no relationship between early range of motion deficits or range of motion deficits later and functional mobility. So at the same time, when we look at strength, quadriceps strength, we see a pattern. This is a combination of a couple of different studies, and we see a pattern where early after surgery, within the first 48 hours, we see a drop in quadriceps strength of about 80%, and walking distance correspondingly decrease. And then at 4 weeks, we still see a 50 to 60% deficit in quadriceps strength. 20%, some of that's attributable to an activation deficit, which I'm going to explain. Similar parallel findings in terms of deficits in functional performance. Depending on which study you look at, the magnitude of the deficit might be slightly different. But then a year or more after surgery, we still see 40% deficit in quadriceps strength and substantial deficit, depending again on the study and the activity that we're asking patients to do in terms of functional performance. So range of motion generally is restored to fairly functional levels, but quadriceps performance and quadriceps function is not. So when we look at quadriceps strength loss after knee replacement surgery, what we see when we look at healthy individuals is that healthy adults have about this amount of quadriceps strength normalized to body mass. Before surgery, patients with osteoarthritis have a substantial reduction in their ability to produce the same amount of force. And then a month after surgery, that's further impaired. That's a pretty substantial deficit. So look at this compared to the healthy controls. And then 3 and 6 months, and we do have data at a year that's not that different from 6-month outcomes, that suggests that they're no better than they were before surgery. So we're basically getting back to their pre-operative levels of muscle strength. How does this translate into functional performance? Well, we see a very similar pattern. So we have healthy adults who can do a stair climbing test relatively quickly. Before surgery, patients are impaired, almost have double the time to perform the same task or significantly slower. 1 month, further impaired. 3 months and 6 months, they're not a whole lot different from that preoperative value. And again, we have 1-year data to further support the fact that they don't improve much past that 6-month time point. 6-minute walk distance, same pattern, just inverse relationship or in a different direction because longer distances are better. Again, you're seeing the same thing. At 6 months, there's really no difference from pre-op, and they're still substantially different from healthy controls. When we ask patients, what are their perceptions of outcomes? What do the patients tell us? So this is the KOOS, which is a very similar to the WOMAC, but has 2 additional subscales. It has a sports and recreation and a quality of life subscale. The WOMAC has symptoms, ADL, and pain subscales. And so those of you who are familiar with the WOMAC, this is pretty much telling us the same general information. When we look at the activities of daily living scale right here in blue, before surgery to 1 month after surgery, patients consistently, or I should say on average, tell us that they are improved in their activities of daily living. When we look at the pain score, which becomes important in the red there, we see that there's a parallel line there between the activities of daily living and the resolution of their pain. So before surgery to 1 month after surgery, they have less pain. It's not significantly less though. But certainly by the 3-month time point, that's significantly less than they had preoperatively. Now, when we look at their actual performance in our laboratory, so to speak, what we see is, now in this case, the red is now this ADL scale that I showed you in blue on the previous graph. What we see is when we ask them to do the same tasks that are represented in that particular questionnaire, the ADL function, so walking, getting up out of a chair. We use time tests to timed up and go, where we get up out of a chair, walk 3 meters, turn around, sit back down. When we ask them to do those same tests that we've already polled them on, questioned them on how they do, we see a completely different pattern. We see that they tell us they're doing better than they were before surgery, but in fact they're doing far worse on each of those tasks. So very different story. Their perceptions are not aligning with reality. Why the disconnect? Well, it really comes down to the fact that their pain is gone. So when your pain is gone, your perception of what you can and can't do changes markedly. And this is a great example of why, a lot of the studies in the arthroplasty literature are based off of questionnaire, self-report. And this is a great example of why you need a combination of self-report and functional performance assessments in many populations in order to get the full story. It's not that what they're doing is the most important thing. The patient's perception is also incredibly important, because if they feel good about their recovery, that's a really important element of success. But in isolation, if you just use the questionnaire-based assessments, you're not going to really capture what their true deficits are, and you're not going to necessarily know down the road what they might be set up for difficulty or failure that may come back down the road to make other types of tasks or recovery from other types of surgery or illness more difficult. So my contention is that when we look at functional performance and the deficits that we see after surgery, the long-standing deficits, it's not because of pain. Pain's been largely resolved. It's because we are largely focused on knee range of motion as our primary outcome. The knee range of motion assessments are very easy and tangible assessments. It's a means of communication with a physician. My patient, in a note, patient has 110 degrees of knee flexion and 0 degrees of knee extension, easily quantifiable. In fact, it's not uncommon when I'm talking to people who've had a knee replacement, that's the first data point that they give me. They tell me, I got 115 degrees of knee flexion on my recently operated knee knee. So the focus of a lot of my work has been on the quadriceps because I think that needs to be a bigger emphasis in terms of the rehabilitation that we're doing in this patient population. And the quadriceps muscle is been widely shown to be very highly, strengthening the quadriceps, highly correlated with functional performance. And so most of our work really has targeted that particular muscle in terms of function. If we gave the same amount of emphasis to quadriceps muscle strength that we give to knee range of motion, would we see very different outcomes in this patient population? So activation deficits, we have shown, account for a much greater proportion of the postoperative weakness than muscle atrophy. In fact, when I first started working on this line of research, we got a lot of pushback when we wanted to look at markers of muscle atrophy in terms of take muscle biopsies and look at some of the mechanisms that were responsible for the atrophy side of things, because we had published showing that the neural contributions were such a huge part of this equation. People really wanted us to focus on that. So that's where we started. And it's been shown in the literature that patients with large muscle activation deficits have negligible improvements in force even after intensive rehabilitation. So I think this is a really important point, because it's the concept of overload applies. You know, this is a great example of how overload is such a critical piece of getting the outcome that you would like. Because if you have a patient who has a 50% activation in their deficit in their muscle, they're able to load their quadriceps in this particular case, half that of the next patient, and you're doing a high intensity strength training program, you may not actually be achieving a true high intensity overload because you have a substantial activation deficit. So say for those of you who are familiar with 80% of 1 rep max in terms of a high intensity strength training emphasis, you may be thinking you're doing an 80% of 1 rep max based protocol, but it could be that you're doing a 40% of 1 rep max, which is not sufficient in order to get strength gains. And so these activation deficits are not trivial. The activation deficits have also been shown to moderate the relationship between quadriceps strength and physical function with osteoarthritis. So Kelly Fitzgerald and colleagues published a really nice article showing that if you perform a time up and go test, and you take 2 patients that have comparable quadriceps weakness, but one has an activation deficit and one does not. So they're both weak, but one has this activation deficit. The patient with the activation deficit will perform more poorly on that particular task than the patient without the activation deficit. So muscle strength in itself is not always the driver for performance on a functional task. Something about the confidence of performing a task and the ability to carry out that task with confidence influences the performance. Let me see if we can get this video to work. For those of you who have not seen an activation deficit, in terms of how pronounced these can be, this is an individual 2 days after knee surgery, and you can see that on their uninvolved leg, they can do a straight leg raise fairly well, and you're going to see I'm going to cue this individual to lock their knee so that they actually do the straight leg raise without a quad lag, is what we call it, when the lower limb drops just slightly. So they're able to do that fairly effortlessly. That's a typical healthy, normal, straight leg raise. 2 days after surgery, despite the fact that they could do this same task before surgery without any difficulty, they are unable to lift that lower extremity. Now, 2 days after surgery, it's impossible to have the degree of muscle atrophy that would account just in isolation for the inability to lift that lower extremity. So there's a huge neural component early after surgery. So as I mentioned, we've shown that activation deficits account for more than twice the strength loss in patients after surgery compared to muscle size. I'm going to touch back on muscle size because it doesn't mean that muscle size isn't an important piece of this. But this figure illustrates that before surgery, if you look at the dark, so this is quadriceps strength relative to healthy individuals, and the dark areas are the activation deficits. And so when we look at before surgery, patients with osteoarthritis typically do have an activation deficit, but they also have some muscle atrophy. That's the light gray. But a day or so immediately after surgery, they still have the same degree of muscle atrophy, but they have a huge increase in their activation deficit. And that activation deficit does resolve over time. So I get comments and questions all the time, which are very appropriate. If the activation deficit resolves, why do you care? If it's going to go away on its own, why not just let it resolve and focus on just overall treatment of the patient? What I have argued is that when you have this pre-existing quadriceps strength loss that then results in a more acute activation deficit early after surgery, that results around 6 to 8 weeks after surgery, you end up with long-term atrophy because the largest portion of time that you're, from a rehab standpoint, you're focusing the first 2 months of your therapy on the time frame that this activation deficit is present. And if you're not accounting for that activation deficit in the treatment strategies that you're using, you may be missing the opportunity to actually allow the patient to get better than where they were before surgery. So the activation deficit essentially leads to that long-term atrophy that we see. So how do we measure these activation deficits? We use a technique with an interpolation of electrical stimuli that I'm going to demonstrate with a video. But this kind of illustrates the outcome of the test. So if you have a patient that has an activation deficit, this is force on the y-axis and time on the x-axis, and you ask them to kick out as hard as they possibly can, and you superimpose an electrical pulse of stimulation, which is delivered through electrodes similar to what would be done clinically for treatment. If you have an activation deficit, you see an augmentation in muscle force. If you, so in other words, if a patient cannot recruit the quadriceps muscle to elicit a maximum contraction, the stimulation helps facilitate that additional recruitment. And you can quantify the magnitude of that peak, basically. If you have complete activation, you don't see that. You don't see an augmentation in force when you deliver that electrical stimulus. So this is the actual test. So you can
All right. 1, 2, 3, kick out. Go, 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 go. Good, and relax. Nice job. Excellent. Stay nice and relaxed for me. I'm gonna give
And you all, with Dr. Bickle here, is a resident expert in this particular application, this technique. So you all have certainly, some of you may have already seen this in practice. This is an example of someone with complete, or the other leg. So this is the same person, but complete activation. You see that you don't see an augmentation in force. So. The question that I always get is, well, that's great if you can measure it in your laboratory, but what about a clinical application? How would you actually take this into a clinical setting? And we've developed a battery of tests that kind of work together as a combined assessment that we're still working on publishing kind of what's the relationship between this battery and some of our laboratory-based measures. But clinically, this is what's done. We look at, a quad set, the ability to contract, to see movement of the patella and the ability to contract the quadriceps. We look at the ability to perform a straight leg raise without that quad leg, without that lower extremity, or the tibia dropping, basically, when you're doing that straight leg raise, the ability to lock that knee. And then we have a unique extension lag test where the patient is seated, the knee is moved passively into extension, and then we back off by 5 degrees, and the patient's asked to hold it against gravity. And if they're able to hold it without any drop of that lower extremity, then they really do have, they don't have a huge activation deficit. So one of my former PhD students, Michael Body, developed this particular test, and it has been very, very helpful to kind of help bridge between the clinical worlds and the research worlds. So what are the factors? This kind of gets at the question that was asked. What are the factors contributing to this quadriceps activation deficit? There are numerous factors, and I'm not going to go into all of these. I think this group, and certainly the work that's being done here, I should add inflammation to this particular list. We have a fusion that's represented, which I think is a big culprit, but the inflammatory factors and cascade of may also factor into some aspects of this activation deficit. But there's a ton of different pieces, and we've tried to look at some aspects of these over the years, and they're hard to tease apart in isolation. They're often intermixed in terms of their effects. So we have looked at transcranial magnetic stimulation, and we've done this. So transcranial magnetic stimulation involves taking a magnetic field and inducing an electrical current to stimulate the motor cortex to elicit a response in a particular muscle. Well, it turns out that the quadriceps is located fairly deep in the sulcus, and it's very difficult to get to with TMS. Nevertheless, we have done some work in this area. It's just not as comfortable as we had hoped for patients. So the volume of patients that are able and willing to participate is a little bit more limited. What we've tried to do, though, is really look at what's causing this activation deficit. Is it the motor cortex, and is there a signal from the brain, an inhibitory signal from the brain, that's limiting the quadriceps from contracting fully? Is it more due to spinal reflex pathways? So is it more of a local kind of spinal reflex response where the quadriceps muscle shuts down due to the swelling and the pain at the joint itself? And then the testing that I just showed you, the doublet interpolation, the central activation, really measures everything along this pathway. So we're not very specific. When we see an activation deficit, we don't know whether it's coming from deficits of the motor cortex or whether it's coming coming from spinal reflex pathway mechanisms. And there are techniques with TMS where you can do paired pulse kind of paradigms to isolate more specifically what's happening at the motor cortex as opposed to some of these cortical spinal pathways. Whoops. Or to isolate it as opposed to lumping it together with all these other potential contributing factors. So this has been challenging work. I would say that by and large, between our findings and the literature that's out there, right now, the preponderance of evidence suggests that the largest influence really is more spinal reflex mediated, but I'm sure that there's a contribution of the motor cortex that's helping in terms of facilitatory or inhibitory. And the motor cortex may be responsible for helping, may indicate responders and non-responders to who actually whose activation deficits resolve more readily than others. So there's certainly literature in patients that have had a stroke that suggests that the ability to overcome some of the early damage may be mediated by some activity in the motor cortex that kind of overrides some of the deficits, in this case in the spinal reflex pathways, the inhibitory kind of pathways. So I'm going to talk about clinical trials that have, some of these are relatively small, but they've all been kind of targeted at the central question of quadriceps strength. So we're going to run through this fairly quickly because I don't want to run over time here. But this is, if you guys haven't seen the application of neuromuscular electrical stimulation, the idea is you take electrodes, you put them over the quadriceps muscle, you get the muscle to contract. And the first study that we ever did, we did an outpatient basis as part of Lynn Snyder-Mackler's work at the University of Delaware when I was a doctoral student. And we started applying neuromuscular electrical stimulation twice a week in an outpatient setting starting 1 month after surgery. Turns out that's too late to start and it's not high enough of a frequency, one or the other. We didn't see an effect of benefit. But we decided we wanted to apply neuromuscular electrical stimulation early after surgery, within the first 2 days of surgery, and we conducted an efficacy trial in a group of 66 individuals who were randomized to receive NMES or not. And they received the NMES units before surgery, but they didn't use them extensively until after surgery. They received them before surgery just for familiarization purposes and baseline assessments. They had their surgery, and then they received inpatient therapy, home therapy, and then outpatient therapy. And the group that received NMES received that in addition to their normal therapy. For 6 weeks, they were asked to use the neuromuscular electrical stimulation twice a day. And so when we look at quadriceps activation from that clinical trial, now, and again, I'll emphasize that the inclusion criteria for this particular trial were very tightly constrained. We only enrolled patients who had minimal contralateral osteoarthritis because we were looking at 1-year follow-ups on functional performance, and we didn't want the confounder of the contralateral knee progressing or deteriorating over time, as well as no other unstable orthopedic conditions and many other restrictions in terms of BMI, because NMES is best applied when there's not a lot of subcutaneous fat that has to penetrate. And so what we found was that there was not a significant difference in quadriceps activation in terms of statistically significant difference. But if you look at the red, which is the NMES group, versus the control group 1 month after surgery or 3.5 weeks, you do see a pattern, certainly, that the NMES looks like it does improve muscle activation to some degree. More importantly, when we looked at quadriceps strength as our outcome here, we saw a pretty dramatic effect. We saw a 1/3 reduction in the quadriceps strength loss with the use of NMES early after surgery. And that is comparable. So the red is the NMES group and the black is the control group. So where these patients were at 3.5 weeks after surgery was comparable to where patients in the control group would normally be around 6 weeks after surgery. And the same was true of the hamstrings. So we saw a similar pattern where we saw a substantial reduction. Even though we applied NMES to the quadriceps, we probably had some carryover in terms of the electrical stimulation affecting the hamstrings, as well as we think maybe the functional performance of these individuals was better early after surgery, so they had more recruitment of all their lower extremity muscles if they were more ambulatory and functional faster. The stair climbing test represents our functional outcomes here, and you can see a dramatic reduction in the deficits that we normally see in the stair climbing test 1 month after surgery. We're able to attenuate those substantially, as well as with the timed up and go. And you see a very similar pattern where we really essentially speed up the course of recovery, that patients are closer to at 1 month after surgery where they would normally be at 6 weeks after surgery. We also looked at the dose of the NMES, so we quantified the dose of the stimulation, and this shouldn't come as a huge surprise, but we did see a relationship. More is better. So the higher intensity, just like you would expect in voluntary-based strength training programs, higher intensities are better. That was also the case here. We saw a pretty strong relationship, especially early after surgery within the first month. Patients who tolerated the stimulation at higher intensities had a greater attenuation of their strength loss in the quadriceps. So I'll remind you, again, the activation deficit, that was the initial focus. Certainly the expertise here is far greater than my expertise. We've been working in terms of looking at the mechanisms of muscle atrophy, but we've been working on quantifying kind of some of the pathways and some of the aspects of the muscle atrophy component to the strength loss in these patients with neuromuscular electrical stimulation. And I've been working with my collaborator, Michael Toth at the University of Vermont, to take muscle biopsies and look at some of these mechanisms in terms of mitochondrial function, contractile ability of the individual muscle fibers, and muscle fiber size changes. That work is still in progress, so it'll be interesting to see what we're able to, why NMES is so effective, both from the neural kind of physiology end of things, and as well as the muscle physiology end of things, the peripheral aspects. So the second trial that has recently just been completed was an extension of the concepts of overload, basically trying to increase the intensity of therapy. And progressive exercise certainly has been shown to be effective in terms of higher intensities, better, as I've mentioned. And one of the limitations of neuromuscular electrical stimulation is patient tolerance. And wide-scale adaptability of neuromuscular electrical stimulation as a treatment tool is challenging. Therapists sometimes are not comfortable with the use of the devices, the intensity of the device the intensity of stimulation that needs to have a therapeutic effect, and the patients sometimes are fearful of it. So we chose an approach that we really wanted to look at an alternative to neuromuscular electrical stimulation because it was likely to be much more widely adoptable in clinical practice. So we call this that particular study PROG, progressive exercise, being the central theme. And the basis for this particular question stemmed out of having orthopedic surgeons. Some surgeons say, above all else, do no harm, of course, always applies, but don't do any strength training on my patients until they have full range of motion restored. And other surgeons say, absolutely no problem. I don't think your strength training is going to impair my ability to, or my patient's ability to get their full range of motion. And so there were a lot of surgeons that were concerned about aggressive therapy increasing swelling and resulting in decreased range of motion and increased pain, as well as risk for injury. We have now shown that that is not the case. We do not see any greater risk of injury with high-intensity therapy. We do not see any compromise in swelling. We hit patients with a battery of high-intensity exercise early after surgery. But surprisingly, we didn't see as big a difference as we would have expected. In fact, we see no differences between groups with high-intensity therapy. When we break these out, though, into two groups of people who had early activation deficits and people who did not. The people with early activation deficits, which are represented in the dotted red line and the dotted blue line that received high intensity or low intensity therapy, did much more poorly than people who did not have activation deficits. So it seemed like the activation deficit piece was more important than just the intensity of the therapy that we were delivering. The next clinical trial that I'm going to touch on looks at minimally invasive surgery. So you asked the question about trauma and how much does the trauma affect quadriceps function. And so we posed this question as a small clinical trial where we looked at minimally invasive versus traditional surgery. And when we started this work 10 years ago, there was not a randomized control study out there. There were a lot of retrospective studies looking at minimally invasive surgery, but no prospective studies. So my colleague, Michael Dayton, who's an orthopedic surgeon, was the orthopedic surgeon for this particular study, certainly a limitation in terms of generalizability that we had one surgeon. But we were looking at whether or not that there was a difference in terms of surgical approach on quadriceps trauma and function. And what we saw, and I won't go into the details of the surgery, but you can well imagine the gist of minimally invasive surgery is it's less invasive, there's less tissue resection, there's also less visualization of the joint. So that's a big issue when it comes to alignment of the lower extremity. If you can't see what you're doing, and you compromise lower extremity alignment, will that set the patient up for bigger problems down the road? So as much as I'm a huge advocate for quadriceps, restoring quadriceps function early after surgery, if you compromise the actual surgery itself and set someone up to require a revision of the knee at 10 years instead of 15 years, I can't argue that a 10% improvement in quadriceps function is that beneficial. It's kind of that risk-benefit scenario. So you can see here we saw a borderline. Now we only had, this was a small trial, it had 44 patients total, so very small. We saw a borderline effect in terms of quadriceps function. We did not see a statistically significant difference, in part because of the variability of this measure. There is certainly quite a bit of variability. We saw a pattern and a trend such that less invasive surgery resulted in lesser activation deficits, but not statistically significant. And more importantly, the take-home message from that clinical trial and others that have been published since is that minimally invasive surgery does not seem to have the effect that we think it does across the board. We didn't see an effect of this quadriceps strength benefit or the trend that we saw translate into functional performance. So if you don't see an improvement in function, you argue that it's kind of a borderline effect. Doesn't mean that combined, when you put all these things together, you don't see a benefit, but it really, I think now the field has decided and moved away from minimally invasive surgery because of the risks associated with it and the marginal benefits, as other studies have supported our findings as well. We've also looked in a clinical trial, another approach at reloading the lower extremity. So we asked the question, so is this strength loss a result of disuse just by virtue of you have surgery, you're told to protect that lower extremity, and people typically, and you hear this all the time, don't put too much weight on that lower extremity. There's a lot of reasons why people will make those statements. But is that really just promoting disuse? Are you talking about a scenario where someone is on bed rest essentially for their surgical leg for a month, and that's what's contributing to the strength loss post-operatively? And you know, we see substitutions for the use of the quadriceps. We see increased hip recruitment. We see weight shifts towards the unaffected limb, decreased quad recruitment. And is that cumulatively affecting the strength loss? So what we did was we forced patients to load their lower extremity early after surgery. And we did this by having them play games where they were asked to, in this case, you're trying to keep the penguin on the iceberg, and you're forcing them to weight shift a little bit more than they would normally feel comfortable doing. And so this was, we had a variety of games. I think one of the tremendous benefits of this is the patients really enjoy participating in therapy. It's not quite as boring as straight leg raises and other types of exercises. But the challenge with this is that it's a static platform. So the things that we're doing now involve more kind of insole-based devices that will allow for more real-time feedback in addition to this type of feedback for symmetry of movement, and forced loading is what we kind of emphasize. And we did find some preservation of quadriceps strength with forced loading. So there is an element to forcing someone to load their lower extremity does preserve some of their muscle function, as well as it restores more symmetry. So when we evaluated this in our gait lab, and I'm going to move on in the interest of time, even though he will eventually get that ball in the hole. So when we look at this in our gait lab and look at symmetry of movement, you know, we looked at up and down. We focused on knee extension, peak knee extension moment, but we looked at hip, ankle, knee. We do see a significant effect, interestingly enough, longer term. And I think some of the studies focused on motor control. It takes a while to develop new patterns that actually result in change over time. And sometimes, even though therapy only went for the first month and a half or so, the effects were most visible 26 weeks after surgery. And we did see some preservation of quadriceps strength as well. And so the last study I'm going to touch on very briefly is a study where we looked at, our surgeons came to us and asked, I have a great group of surgeons at one of our hospitals led by Doug Dennis, who was interested in the effects of the tourniquet itself. So tourniquets occlude muscle, occlude oxygenation of the muscle. They're designed to reduce blood flow during the surgery so that there's better visualization. But between the reduction in oxygen delivery to the muscle during the surgery, as well as the reperfusion injury that occurs after surgery, the question is there damage to the muscle as a result of tourniquet application? So we published a study fairly recently that really does show, and I was actually quite surprised at that we saw a difference. We looked at patients with simultaneous bilateral knee replacements, so we had a tightly controlled kind of within subjects design. We randomized the leg that received tourniquet and that didn't in terms of the order of surgery. And we saw, indeed, that at 3 weeks, we saw a clinically meaningful and statistically significant effect on quadriceps muscle function. Clinically meaningful we define as about a 10% change. And that persisted to 3 months after surgery. So tourniquet application, again, is important because of visualization. If surgeons do better at the surgery because they can visualize the joint, there may be a good reason to still use tourniquets, but more and more surgeons are now starting to switch towards applying the tourniquet during cementation of the joint. So just for a short period of time when they really need to have good fixation of that cement rather than throughout the entire surgery. So I've gone through a variety of different studies, and now I want to kind of wrap it up by tying it back to my initial question of how do we take some of these findings, tightly controlled efficacy trials that are not pragmatic in nature, and apply them to kind of a real world setting, and where are we going? How can we really make this clinically relevant? One of the take-home messages from all this work has been that quadriceps muscle dysfunction serves as a great model to understand deficits from any other number of musculoskeletal injuries. A lot of these principles apply to various other patient populations. And the muscle activation deficits should be considered in conjunction with the other intervention strategies. But again, how do we translate this? How do we take an individual that's having a knee replacement surgery and end up with a successful outcome based on what their individual goals are, what their individual physiology is, and what their capacity is? And we really are starting to look at how do we tailor individuals to address patient-specific deficits, right? So instead of, all these clinical trials are designed to, even as small as some of them are and as large as some of them are. The largest one of the ones that I presented had 162 patients that were enrolled. That was the progressive exercise trial. We still are lumping everyone together into one pool and looking at averages across the population and basing our treatment recommendations based on those averages. And so if we could work on combining what are the patient goals as well as what are the specific deficits that a patient has. So could we develop tools, could we develop algorithms and strategies that assess symmetry of movement early after surgery, and in patients who have a deficit in that area, apply rehab strategies that address it early? Could we look at patients who have activation deficits and treat them differently? And so a lot of our current directions involve looking at more of this individualized approach to intervention instead of lumping everyone together into one pool. And so we need to figure out, especially in our current payment model, bundled care kind of structure, how we're going to allocate these resources more precisely. So the standard of care right now is that everyone receives PT 2 times a week for 6-ish, maybe 8 weeks after surgery. Pretty prescriptive. Pretty much the surgeon writes you're going to go to PT for this length of time and this frequency, and that's typically what's followed. The question is, do we really need to be doing it that way? And so we're looking at individualized patient prognoses where we look at a historical data set and we develop using mathematical modeling with some collaborators in the Netherlands. Stefan Buren certainly is one of the leaders in this field. And we're looking at if you have a patient who, based on this database of historical controls, should look somewhere in between these gray lines, but comes into your clinic and looks like this green line, could you change the frequency of delivery of your services? And could you spread out those services in order to achieve better effects in the long run? Versus a patient who has a poor outcome early after surgery and needs intervention in order to prevent something that's going to be much more catastrophic in terms of the need for a manipulation if their range of motion is severely impaired, or other issues or problems that they may encounter, so that we reduce costs on the back end. We need to find these patients that need early intervention, that fund the black line, that fall below kind of the expected range where they should be, deliver more services early to those patients, and then again spread out the services later once they're back on track. So instead of having this one size fits all, we're going to treat all patients the same, how do we individualize that? And I think right now with the CMS guidelines that have been issued, right now there's a huge emphasis on just slashing rehab. Let's get rid of rehab. Let's decrease the frequency, do the surgery. Our cost savings are going to be greater. I think a much more effective approach, and it's going to take a little bit to develop some of these guidelines, is to provide more precise data-driven rehab schedules that are tailored to patients' needs, so and tailored to the individual deficits that they have. Some of our surgeons, have gone so far as to say they're not going to use rehab, they're going to send people home with a video-based home exercise program. And I think that we need more data to show that really the cost of one rehospitalization is it's a fairly costly event, and the cost of rehab really isn't all that great proportionally to the cost of the surgery. And so a little ounce of prevention goes a long way towards catastrophic or adverse outcomes. So I will conclude there. My kids, I have a 5-year-old and a 4-year-old, are always forcing me to test the limits of trying to think differently about how to approach some of these questions. And I am tremendously grateful. My research program is largely focused on joint arthroplasty, but more recently, our CU Restore group, which is kind of the bigger umbrella, is focused on questions of older adult populations, including home health and skilled nursing facility, that go beyond joint arthroplasty. And I'm tremendously grateful. This is, as you all know, and as being largely involved in research in the audience, that this work is a result of a lot of efforts of a very talented group of individuals, both the combination of mentors and students. Particularly Wendy Court has been a phenomenal mentor throughout the years to advance these efforts. Corey Christensen is the biomechanist that works closely with me on many of these lines of research and was the PI of the biomechanics study that I described, the low movement asymmetry study. Andy Kittleson's the one that's developing, he's a PhD student who's developing some of the mathematical models for individualized patient treatments. Michael Body developed a lot of the progressive exercise paradigms and some of the biomechanics asymmetry reloading intervention strategies. And then I have 2 surgeon collaborators who have really led the charge amongst many of these people in terms of many of the arthroplasty studies. So with that, I will end and thank everyone. And I'm happy to take additional questions. I really appreciate your attention. This is our CU Restore group over at the University of Colorado. Most of I have a number of PhD students and postdocs, but it's we also have a number of DPT students that are actively involved in our research program. So thank you.
I just have to weigh in on that.